Good morning. Welcome to the Department of Medicine Grand Rounds. Before we start, I want to celebrate Mariusz Radaszak. And many of you know Mariusz Radaszak. You'll see him walking around. He's one of our researchers. He's professor of medicine. He's a member of the Cancer Center. He's done a lot of good research in stem cell biology, discovered some new kind of stem cells that have become quite interesting. And he's originally from Poland. And the president of Poland just gave him the Gold Cross of Merit, which is given to citizens who have gone beyond the call of duty in their work for country and society as a whole. So if you see Mariusz, just stop him and congratulate him. This is a big deal. I also want to celebrate the BMT group. Dr. C and his group are here, and they just received the International FACT accreditation, F-A-C-T. I don't know what that stands for, but it's a big deal. There's only one program in Kentucky that has both pediatric and adult components that have been accredited for this. So congratulations to the gang. And they actually will house and host in April 8 and 9 the first Jeffrey Hersick Memorial Symposium on hematologic malignancies and bone marrow transplantation. So that will be fun. A lot of people from around the United States and other places are going to be coming here. So be ready, because this will be fantastic. And thank you guys for setting all that up. Today, back in 1862 was the birth of Arthur Nicolear. Nicolear was a German physician and bacteriologist, and he actually discovered tetanus bacterium in 1884. He was unable to isolate it pure, so he couldn't isolate it pure. That was done by Kitsato later on, but he discovered it was in soil. He could inject portions of it into mice and create tetanus. Later on, that led to the discovery of the Clostridium tetanus toxin. And by World War I, essentially by 1915, all soldiers were actually injected with antitoxin agent to make sure that they didn't develop this in dirty wounds while they were in war. He died at age 80 in 1942, pending wartime internment as a Jewish person, probably by suicide. And then I want to remember John Gibbon, because today is about heart failure and cardiology. I don't know if our speaker knows who John H. Gibbon is. Okay. So John Haven Gibbon was an American surgeon who invented the heart-lung machine. And he was prompted in 1930. He was a resident in surgery at Harvard, and he attended a heart-lung surgery, and he saw the patient essentially suffocate in its own blood. That's the way he described it. And he got intrigued about this, and by 1935, he had built his first external pump and was able to maintain cardiac and respiratory functions in a cap. And later on, he started getting grants and so forth, and he was funded by the IBM Corporation to develop an oxygenator with sufficient capacity for a human. So by May 6th of 1953, he improved the machine and was able to perform the first successful open heart operation. He basically repaired an atrial septal defect in an 18-year-old called Cecilia Bobolek, maintaining the patient's heart and lung functions on the machine for at least 26 minutes. And with that, I leave you with Dr. Emma Burks, who's going to introduce our speaker of the day.
Thank you, Dr. Roman. Well, it gives me very great pleasure to introduce Dr. Abramov to give the Medicine Grand Rounds today. So he joined us in the Division of Cardiovascular Medicine and within advanced heart failure and transplantation just last July. I would say he's made a huge difference already. He's been extremely hardworking, very thoughtful, and we're delighted to the improvements he's made to our group. So he went to medical school in Albany Medical College, New York, got his MD there with magna cum laude. Prior to that, he did an MS in health administration in New York. He went on to do his internal medicine registry program in Columbia, and there he was awarded Physician of the Year. He then did his cardiovascular fellowship in Washington Hospital Center, Georgetown in Washington, D.C., and went on to do an advanced imaging fellowship there in Washington as well, and then went to Vanderbilt to do his advanced heart failure and transplant fellowship. So he has additionally a lot of experience and training in imaging, so he's improved our heart failure imaging a lot, working with Dr. Stoddard, our existing imagers. So we have, I think, a much better service there now. We're also trying to grow the heart failure program further with him and Dr. Vijay Krishnan. And he's really been an incredibly hard worker, a very welcome addition and a great team member. He already has an abstract in the International Society of Heart Transplantation in April and is already being incredibly productive. And with that, I'd like to invite him to give grand rounds today on patient evaluation for advanced heart failure therapy.
Thank you, guys. So we'll talk today. Can you guys hear me in the back? About patient evaluation for advanced heart failure therapy. I have no disclosures. So the goals for today are a few. So we'll talk about the classification of advanced heart failure, just so we're on the same page about what advanced heart failure is. We'll talk about briefly the options that are available in terms of what we say when we speak about advanced heart failure therapy. We'll talk about how to identify end-stage heart failure, which is actually more complicated than it appears. And then we'll talk a little bit about candidacy for advanced heart failure therapy. So the background, so I think we all know this. So heart failure is very prevalent, the leading Medicare diagnosis in terms of cost for the system. So a lot of morbidity and mortality in the United States. Generally, when we talk about heart failure, obviously we talk about systolic heart failure, so people with a low ejection fraction, as well as what used to be called diastolic heart failure, which is heart failure with preserved ejection fraction, as most commonly called now. And both of these are have the potential to cause advanced heart failure and the potential to need advanced heart failure therapies. We'll also talk briefly about the classification system, so the ones that people are familiar with, the NYHA class, and then the ones that are a little bit potentially less familiar to people, such as the Intermax classification. So these are the most common classifications for heart failure severity. The reason to know these is it allows us to communicate as providers between each other. It allows us to risk stratify patients a little better when we think about them. And so the ones that have been used most significantly are the ones at the top, so the NYHA class, and then the ACC-AHA, which stands for American College of Cardiology and American Heart Association group. So these approximately line up. So patients who are ACC-AHA group A are patients at risk for developing heart failure, so patients potentially with just hypertension or diabetes. Those in group B are patients who are asymptomatic but have developed structural heart disease, so either they're starting to develop diastolic or systolic dysfunction. Group C are patients who are starting to have symptoms, but potentially only mild symptoms, and D are patients who have very advanced symptoms. I would say this terminology is somewhat important, but not commonly used anymore. NYHA class is very commonly used, so patients who are class 1 are asymptomatic. Those who are class 2 or 3 have sort of an increasing amount of limitations, with patients who are class 3 having essentially limitations due to heart failure for minimal physical activities, such as I would say walking up a block or less, or climbing a flight of stairs or less. And those NYHA class 4 are patients with very advanced heart failure symptoms, so symptoms either at rest or essentially with very minimal physical activities, such as doing activities of daily living. So this classification system was pretty good, but it turns out that a lot of patients who go on to require advanced heart failure therapy have this class 4 group D heart failure severity, but this is a very large group, and so there have been classification systems developed in order to try to even further risk stratify patients within the more advanced heart failure stages. And so that's where the Intermax Profile came out. This was a system developed both so that physicians can better communicate among themselves about patient severity, but also for research and other purposes. And this terminology being increasingly used in the literature, which is why I think it's important to discuss. So as you go down here, the severity of illness goes down. So profile 1 are patients who are critically ill, cardiogenic shock, patients who are essentially crashing and burning. Those who are profile 2 are patients who require inotropes but are also not doing well, so deteriorating. Those who are profile 3 are patients who are stable on inotropes, and then going down to patients who are progressively less sick, although again, all of these are subclassification of essentially class 4 heart failure. The other reason this is important is because this gives you a time to think about when we may need to think about doing something in terms of advanced therapies for heart failure. MCS here is mechanical circulatory support, so potentially something like ECMO or VAD or some other therapy. And essentially, these patients require something within hours or they're going to die. These patients probably within days, these within weeks. But then as heart failure technology gets better and we think about treating more patients, then we're all trying to find more and more of these patients, which is primarily what we're going to be talking about for the rest of the talk, and think about when they potentially may be candidates for advanced therapy. So briefly, heart failure is predominantly a disease of the elderly, although there's a significant number of patients who you guys probably see in your clinics who are in their 20s, their 40s, their 60s who have significant heart failure. So just because somebody is young does not mean that they do not have significant heart failure or that they wouldn't benefit from advanced therapy evaluation. So the heart failure prognosis is pretty poor, which is why we need to think significantly about how to identify these patients, how to treat them, and potentially how to treat them with advanced therapies if that needs to be the case. So for the general population, the 1, 2, and 5-year survival are about, so the adjusted mortality rates are about double compared to the normal population. And this is just for anybody with a heart failure diagnosis. Once patients are hospitalized, recurrent hospitalizations are common, so about a third will get readmitted in 30 days, and 1-year mortality is about a third. So this is for everybody who gets hospitalized with heart failure. So pretty significant mortality and morbidity burden. Among patients with more advanced heart failure, class 4, things are pretty grim. So 6-month survival, 50%, 1-year survival, 20%. And if you compare these to malignancies, class 4 heart failure has the same survival as metastatic pancreatic cancer. So, I think people, for the most part, say, "Oh my God, I have pancreatic cancer. That's horrible. I'm gonna die." But a lot of people say, "Oh, it's just heart failure. That's something that's probably okay." Whereas in reality, heart failure is really a pretty devastating disease. This is data a little old, but still probably accurate, comparing essentially the outcomes after a first heart failure hospitalization. So for a 70-year-old man and a 70-year-old woman, and again, this is any heart failure hospitalization. And in the year 2000, so for a man, the survival is not as good as prostate cancer, about the same as colon cancer. So again, so heart failure for any hospitalization is about the same as being hospitalized for colon cancer. And for a woman, again, similar to colon cancer, but worse than having breast cancer. So it really implies how significant the comorbidities are from heart failure. So when we talk about heart failure treatment options, what kind of things are we talking about? I think medical therapy is still the cornerstone of treatment. And when patients are referred to us or the heart failure cardiologists, not everybody will get a heart transplant. The vast majority of patients are still treated with medical therapy. We also make sure that patients, if they're candidates, will get appropriate defibrillator or biventricular pacemaker therapy. And then once those fail, or we think the patients aren't doing well, we start thinking about more advanced options, which are the 3 specifically are inotrope therapy, ventricular assist device therapy, or heart transplantation. So what's inotrope therapy? So mostly of historical interest, although still somewhat used today. So we're talking about intravenous continuous infusion of milrinone and dobutamine through a PIC for patients at home. Both provide hemodynamic improvements, so will improve cardiac output, potentially improve filling pressures, pulmonary pressures. However, both have been associated with increased mortality, probably because they're pro-arrhythmic. Right? If you think about beta blockers improving mortality in heart failure, it's not hard to believe that beta agonists would worsen mortality. And so these are still used rarely, but breast uses a bridge. So for patients who are undergoing evaluation for more definitive heart failure therapy, so either ventricular assist device or heart transplantation. Meaning that if you're seeing somebody in your clinic or out there in the community who is on inotropes, that patient really needs to be either very quickly referred to somebody where they could be evaluated for more definitive therapy. Otherwise, home inotrope is essentially a palliative or hospice therapy. So heart transplantation is still the gold standard when it comes to advanced heart failure therapy. The problem with heart transplantation is that over the last 20 years or so, the number of donors and transplants in the United States is between 2,000 and 2,500 and is really unlikely to increase despite attempts. So for all the hundreds of thousands of patients who have heart failure, only a very small percentage will wind up getting heart transplantation. Most people who get heart transplants are obviously in the 40 to 60 age range, but that does not mean that either very young people or the elderly should not be referred to or considered as being candidates for heart transplantation. Just briefly in terms of outcomes for heart transplantations, they are pretty good. So these graphs demonstrate the outcomes in the most recent era within the last 10 to 15 years. Essentially, the median survival in the current era is probably going to be in the 13 to 15-year range. which is pretty good because, if you're 60 when you get your heart transplant, that's not too far. You're likely to live well into your 70s with a heart transplantation. So this is pretty good heart failure therapy. So ventricular assist devices are sort of the new kids on the block that have started to emerge over the last 5 to 10 years as the technology for ventricular assist devices have really improved. These are just some pictures about older pumps, which this is probably 3 or 4 inches across, huge, big pulsatile pumps. And as the pumps are improving and decreasing in size, the ones that we're currently using clinically are this one, which is the HeartMate 2, and this one, which is the HeartWare pump. These are about 2 inches in size and fit well within the chest when they're implanted. The next generation will be even smaller. This pump, which will hopefully come out soon, is about the size of your thumb that's implanted. So as technology gets better, the number of implants for continuous flow pumps, which are the red and the blue here, have been pretty significantly increasing and now occur at about the same rate, if not more, than heart transplantation across the United States. And this is going to increase pretty much exponentially as the technology gets better in the next few years. Just a word about, for those people who are not very familiar with ventricular assist devices or what they're like. So this is a picture. So they're surgically implanted. For the most part, they require sternotomy. There's an inflow cannula that will go into the left ventricular apex, so the blood will be sucked out of the left ventricular apex. It will go through this pump. The pump is continuous flow, so essentially there is a rotor here that rotates continuously. In this pump, it's about 10,000 revolutions a minute. And then it pumps the blood and connects somewhere to the ascending aorta. So it essentially bypasses the whole left ventricle. The problems with this pump are, quite significant at this point. The first is that the battery requirements for the pump are really significant. So unlike a pacemaker, which could be totally implantable, these pumps cannot be totally implantable. So this requires a drive line that exits somewhere in the stomach and is attached to a controller as well as batteries the patients wear at all times. The batteries can be changed. They last 8 to 12 hours. But still, there's a significant morbidity associated with this pump because of this. The current technology that's used is all continuous flow, so the rotor spins continuously in these pumps, which provides some interesting hemodynamic results because many of these patients have no pulse anymore. If their native heart is so weak that it can no longer generate enough pressure and all of the flow is going through the pump, these patients' aortic valve will not open and they will have no pulse. So these pumps are implanted, and this technology is commonly used in the literature, which is why it's important to know. So there's 2 terms. One's called bridge to transplant, and one's called one's called destination therapy. So bridge to transplant means you put in these pumps with the hope that these patients will one day soon get a transplant. And so these pumps are essentially put in as a bridge to stabilize people and allow them to remain stable on the waiting list until a heart becomes available. Destination therapy is for patients who are, for one reason or another, not transplant candidates. And so they would get this pump with the understanding that they would have this pump for the rest of their lives. So, for example, we'll talk about this a little later, but if patients are elderly or they have other comorbidities and they're not candidates for transplant, they could get this pump and live 3, 4, 5 or more years with the pump doing reasonably well. Some patients are actually also able to be recovered when you put these pumps in. Obviously, some patients with heart failure, because their heart is so weak, are not able to tolerate medical therapy. And with these pumps in place, it allows significant up-titration of medical therapy. And Dr. Burks is actually a world leader in doing this to patients. And there's a trial run out of here in order to try to better categorize myocardial recovery in transplant patients. So I showed you the survival for heart transplantation, and then we talked about the survival of patients, of advanced heart failure patients on medical therapy alone and how dismal that is. So are VADs better? And the answer is yes. So the newer generations, and this data is already pretty much 10 years old. So the newer generation continuous flow pumps have a 1-year survival of at least 80%, and more recently probably closer to 85 to 90%. In patients. So all of a sudden we've improved with this technology the survival of patients at 1 year from 20% up to about 80 to 90%. So this has been significant improvement in mortality for end-stage heart failure patients. There's also significant improvement in quality of life for these patients. So this is these two graphs. This is bridge to transplant population, which is a little bit healthier, and destination therapy population, which is a little less healthy. And this is over time. So this is 1 month post-implant, 3, 6, and 12 months. And you could see that at, let's say, 6 months post-implant, you're taking patients who are all class 4, and now the vast majority of patients are class 1 or class 2, so essentially have minimal heart failure symptoms. So that not only are we improving survival in these patients, but we're actually improving their quality of life and allowing them to do more. And I would say that with heart transplantation, these would actually look even better for improvement in functional status. And when we think about referring patients for these significant things like heart failure, for heart failure therapy, so that or transplant, you want to know that when you're referring patients that they're going to be satisfied with their decision in the long run. And based on the improvement in morbidity and mortality, most patients, based on recent data, are pretty satisfied that both patients think that, for example, getting a heart pump was for the most part the right decision for them. Very few patients will regret their decision. And then the patient's caregivers, so their family, which is also pretty important because these are significant burden to both the patient and the family, at least in the beginning, also feel, strongly agree that it was the right choice for them to essentially be referred and undergo heart failure therapy. And so this, this same study, in the next slide, addresses some of the things that patients said about the referral and being referred for heart failure therapy. And this is my first plug for reasons why patients need to be referred early. So patients say things like this, why at the outset hospital did they take so long? Why did they let me suffer for years, get shocked with my device when I could have gotten the VAD and felt stronger? Why did they wait until I was about to die before they decided that I was a candidate for therapy? With this patient who said, after my transfer to the VAD program, the evaluation was very quick. They told me that things were urgent. I thought they were going to wait months, but they said, no, you need surgery this week. What this patient said, by the time I got to the VAD center, they said I needed a surgery or I would have died. So all of these patients, obviously, were patients who were probably referred later than they should have, and highlights, I think, some of the frustration that patients have because of the severity of their disease. And now that there are options for treatment, I think patients really should be referred as early as possible. So when we think about who to evaluate or how many patients there are in the United States who may be candidates for advanced therapies, there are probably a lot of patients. So these are patients that we're probably all seeing in clinic, some of which recognize, some of which not. Out of the 300 million patient population in the United States, about 2% or so have heart failure, out of which about half have preserved systolic function, so heart failure with a preserved ejection fraction. The other half have systolic heart failure. Out of these, the vast majority are actually doing well, are asymptomatic, but a significant percentage have more advanced class 3 or class 4 symptoms, which leaves a few 100,000 patients, out of which, if you just look at the ones with the most advanced class 3 symptoms, as well as class 4 symptoms, plus the ones who are under age 75 and would most likely be candidates for therapy, you're still looking at a few 100,000 patients in the United States. Now, this is probably prevalence, but still, because of the significant mortality of these patients without therapy, there are probably tens, if not hundreds of thousands of patients every year who are potential candidates for advanced heart failure therapy. And I showed you that about 2,500 a year will get a transplant, and maybe 3,000 a year will get the VAD, which means that there's still a huge undiagnosed, or there's a huge population of patients potentially right now who are not benefiting from this therapy. So what do we think about, or how do we know who to refer? Because I think this is not a simple question. This requires some experience. And there's several ways to think about this. And we'll talk about some subjective and some objective ways to try to figure out which patients need to be referred for therapy. So the first, and I think a lot of clinicians will have this. So they see a heart failure in clinic, and the patient is just not doing well. Maybe you can't really put your finger on it. Maybe you're not really sure, but you get like a sense in the room that something is wrong. This patient's really not doing well. That's a time when you probably should consider referring that patient to a cardiologist or to a heart failure center. There are also objective measures. So we'll talk a little bit about patient hemodynamics, about their functional status, about their nutritional status, and then about the risk scores that are available that are pretty well characterized in order to try to risk stratify patients. And the goal really is to identify patients before they're too sick to be referred, both to avoid some of the patient quotations that I showed earlier, as well as the fact that once people are too sick, once they have too much end organ dysfunction, then potentially they have missed their window to benefit from these therapies. There are also various etiologies of heart failure out there. So ischemic and non-ischemic are the two that are most common, but a lot of patients have restrictive cardiomyopathy, have amyloid or hypertrophic cardiomyopathy. And just because somebody has amyloid or hypertrophic cardiomyopathy does not mean that they don't have either advanced heart failure or that they potentially are not candidates for advanced heart failure therapy. Particularly with amyloid cardiomyopathy, there's more and more work done now between between the heart failure groups and hematologists, so that people with both AL amyloid as well as TTR amyloid, so even if your amyloid is due to multiple myeloma, there's still a fair possibility that you may be a candidate for advanced therapies. There's no specific age cutoffs when thinking about when to refer patients. Patients in their 70s, like I showed you before, may still get a heart transplant, and certainly patients well into their 70s and 80s have been implanted with mechanical, with bad therapy, with significant success. So it's useful to look at definitions of advanced heart failure, and there are a lot of these out there, and this provides some both subjective as well as objective data for what to look for when trying to figure out whether the patient that you're seeing in clinic or in the hospital with heart failure truly has more advanced heart failure than people may realize. So there are clearly some subjective signs. So I talked about the NYHA class 3 or class 4 symptoms. So dyspnea or fatigue at rest, people who have symptoms with minimal exertion. Patients who have repeated evidence of fluid retention, so people who have multiple heart failure hospitalizations, who come with pulmonary edema or systemic congestion, peripheral edema. Those patients who, for one reason or another, are found to have reduced cardiac output at rest, whether they have a right heart catheterization, a Swan-Ganz catheter put in, or you find out that they have low cardiac output by ordering a cardiac MRI or an echo. Those patients with low cardiac output probably have advanced heart failure. There's a number of objective pieces of evidence. So people with severe LV dysfunction, those with evidence of significant diastolic dysfunction on echo, those with evidence of elevated filling pressures on catheterization, those potentially who have very high BNP or pro-BNP values, those patients who are unable to exercise, who are not able to walk very much, and we'll talk more about cardiopulmonary stress testing in the peak VO2. Those patients who have multiple heart failure hospitalizations. As I mentioned, heart failure is the most common reason for hospitalizations for the Medicare population. And so we see many patients, both in clinic as well as in the hospital, who we know had repeat heart failure hospitalizations. And those patients, unless we could find a way to better optimize their heart failure therapy, potentially need a referral for more advanced therapy in order to try to break this cycle. And all of this needs to be despite the presence of attempts to optimize heart failure therapy. So meaning that patients are on, this is goal-directed medical management, meaning their beta blockers, ACE inhibitors, spironolactone, other medications are fully optimized, and they get, for example, biventricular therapy if that is indicated. This is also from the ACC/AHA, so the cardiology societies. So clinical events and findings useful to identifying patients with advanced heart failure. So some of the similar things as from the European guidelines. So patients with multiple hospitalizations. This is important. Patients with deterioration in renal function. So patients who are going along, they're doing well, and then all of a sudden you're noticing that their BUN and creatinine are starting to rise. and there's no other reason that you're able to identify for the rise. This potentially is due to either very elevated chronically elevated filling pressures or poor perfusion, and this is a very concerning sign. Patients with weight loss for no other causes. So cardiac cachexia is absolutely real. So patients with heart failure who have unintentional weight loss, that is a very concerning sign. We recently referred a patient who, with heart failure, who had very significant weight loss, and he was first referred to all other specialists. So primary care, hematology, oncology, got a bone marrow biopsy, had a lot of other evaluation, was eventually referred to us and had a cardiac index of 1.3, which is really what explained why he was clinically not doing well. So cardiac cachexia is absolutely real. And when patients' nutrition suffers, when you're noticing low albumin or prealbumin levels, that is a very concerning sign in the presence of heart failure. So we see this a lot. So intolerance to ACE inhibitors or beta blockers. So when you're finding that with your clinic patients or on the inpatient side that you're having to reduce heart failure medication doses particularly because of low blood pressure, because of patient fatigue, that is evidence that the patient's heart failure is probably more significant than may be appreciated. Frequently low systolic blood pressure. So if the blood pressure is running less than 90, again, this will probably require you to think about reducing ACE inhibitors and beta blockers, and this is a concerning sign. Persistent dyspnea when doing activities of daily living. So those patients who say, I can no longer wash myself, I cannot brush my hair because I get short of breath. Those are obviously very concerning signs. Patients who can't walk a block, patients who need escalating diuretic therapy, or you're starting to add diuretic boosters, so metolazone, to patients on a regular basis. So those are patients who probably have significant heart failure. Low serum sodium is a very concerning sign in end-stage heart failure, as well as having frequent ICD shocks. So there's obviously a lot of reasons why heart failure patients can have ICD shocks. It could obviously be due from ongoing ischemia, but having elevated LVEDP, so an elevated left ventricular and diastolic pressure, is very likely to cause this because it decreases coronary perfusion. So whether patients are ischemic or non-ischemic, if they have very elevated filling pressures, that very much will increase the risks of having ICD shocks. And we frequently find that for patients with essentially refractory ventricular arrhythmias, that the only way to treat those is to unload the ventricle with something like a ventricular assist device. So some more signs and symptoms of advanced heart failure, particularly from the clinical exam. Signs-wise, from physical exam, these are the ones that are highlighted. So elevated JVP, third heart sound, rales, edema, cool extremities, hepatomegaly. In terms of symptoms, the ones that I want to particularly comment on is fatigue. So a lot of patients will not get short of breath or will not describe classic shortness of breath or dyspnea and exertion because just like with many other cardiac diseases, patients will limit what they're doing on a daily basis in order to not bring on those symptoms. So patients will no longer go for a walk. They will no longer go to their mailbox. They will no longer go to the mall. And that's because they're just tired all the time. So they may say, no, I don't get short of breath anymore. But when you ask them, what kind of things are you doing? The answer is nothing. And that's because they're really very fatigued. And this is sort of similar to patients with severe end-stage valve disease like aortic stenosis, where patients will reduce the amount of things that they do in order to not bring on symptoms. Anorexia, we already talked about the importance of that. Syncope is also very significant, whether that's due to cardiac arrhythmias or low blood pressure or hypoperfusion. Those are very significant clinical signs. In terms of vital signs, so both hypertension and hypotension are potentially concerning. Pulses alternans and abnormal Valsalva response are kind of esoteric clinical findings, but a narrow pulse pressure is something that we very commonly see. So if you see a patient in clinic with heart failure who has a blood pressure of, let's say, 95/75, or 90/75. So somebody with a very narrow pulse pressure. So pulse pressure is a surrogate for stroke volume. So those patients with low pulse pressure are very likely to have severe heart failure and low stroke volume. So how good is the physical exam? So I think not too good, actually. So this is data from the ESCAPE trial, which was a trial of treating advanced heart failure patients with Swan-Ganz therapy. And so what they did is they had seasoned heart failure cardiologists evaluate patients with physical exam, and then they correlated that to elevated filling pressure, so a wedge greater than 22, or a cardiac index of 2.2 or less, and to see how well seasoned clinicians could pick up these findings. And the answer is, as you could see, not too well, actually. So rails, poor sensitivity, although good specificity. S3, essentially coin flip. Edema, not that great either, partly because edema is largely an extravascular fluid issue, whereas elevated wedge pressure and JVP are intravascular fluid issues. And so obviously somebody could have very elevated intravascular filling pressures without having extravascular manifestations like edema. Orthopnea, pretty good, although not, obviously not present in that many people. Excuse me. Other things, hepatojugular reflex. It's good if it's there, but not present in many people. Even JVP, so JVP greater than 12, essentially is a coin flip for whether or not these patients are going to have truly elevated filling pressures, partly because it's actually very clinical. It's pretty difficult, despite the fact that everybody says it's easy to look at somebody's neck veins and figure out their filling pressure. The truth is that's not the case even among seasoned clinicians. And actually, a lot of patients with an elevated filling pressures have a low wedge pressure on exam, so about 5%. And that's because jugular venous pressure really reflects right-sided filling pressures versus the wedge pressure reflects left-sided filling pressures. And in patients with advanced heart failure, there could actually be a dissociation between the right-sided filling pressures and left-sided filling pressures. What about the ability of the physical exam to detect cardiac index of 2.2 or less, which is essentially cardiogenic shock? So again, not too great. So a low pulse pressure has a high specificity but low sensitivity. Hypotension, not that great. The best, like I was saying, really is fatigue. So those patients are chronically fatigued. This is the best thing to see whether or not somebody has low cardiac index. And then cool extremities, and even whether the heart failure cardiologist thought that the patient was going to have low cardiac output, the sensitivity of that is extremely low, which suggests that overall the physical exam, while extremely useful, and we do it every day and we rely on this, the physical exam really, in my opinion, is what you use. And then if you have a lot of clinical suspicion, you need more objective data to confirm that. So with things like a Swan-Ganz catheter. So what about objective risk scores? So there's a number of these that are available. The three that we'll talk about are the Seattle Heart Failure Model, the Heart Failure Survival Score, and cardiopulmonary stress test data. So the Heart Failure Survival Score, so this was derived essentially in the 1980s among heart failure patients who were referred for heart transplantation. And the risk factors that they identified as being identified with worsening survival are these. Now, the numbers themselves and the calculator is not important, but essentially it was things like ejection fraction, heart rate, sodium, blood pressure, and this was really the first set of papers that popularized the concept of using cardiopulmonary stress testing, so the peak VO2, in order to risk stratify patients. Briefly, the indications for cardiopulmonary stress testing from the American societies, and this I think is a somewhat underused test for advanced heart failure evaluation. So if you're evaluating the exercise capacity of patients who you're thinking about referring for advanced therapies, that is a class 1 indication. if you're evaluating the exercise capacity of patients for whom estimates of exercise capacity are unreliable, so you're just not sure. So the patient is vague about how much physical activity they're able to do, but you're concerned that they may be either overestimating how much you're able to do or you have concerns for other reasons. Those are patients who should be sent for cardiopulmonary stress testing, because what you get from that is a number, so a more objective way to quantify patients' functional capacity. When you think about cardiopulmonary stress testing, it's really not that different from a regular stress test, except that the patients wear this mask, which measures their oxygen consumption and their CO2 production. And so you essentially get three numbers from that test that I think are important. You get the peak VO2, so this is the amount of oxygen consumption that the patient is able to consume with physical activity at peak exercise. And anything less than 10 to 14, so really anything less than 14, is pretty severe impairment in their functional capacity, and those patients have very much poor outcomes and should be referred for advanced therapy. This VO2 needs to be interpreted in the context of something called the respiratory exchange ratio that's reported on these testing. This indicates that the patient met anaerobic and aerobic threshold. And this number needs to be above 1. If this number is not above 1, that potentially means the test was submaximal for a variety of reasons, and that peak VO2 may be underestimated in those cases. Nevertheless, I think anytime you see a peak VO2 of less than 14, that is concerning. The other risk score that is pretty popular, this is an online risk calculator, the Seattle heart failure model. Also derived from essentially stable outpatients. And this model is pretty cool because it gives you the patient's 1, 2, and 5-year survival. It gives you their median life expectancy. And the things that it requires are pretty easy. Unlike the heart failure survival score, you do not need weird testing like cardiopulmonary stress testing. This is essentially information which is easily available by physical exam or labs on patients. So their age, their sex, NYHA class, their weight, ejection fraction, blood pressure, whether they're ischemic or not, and then their diuretic doses and their laboratory data. And the other neat thing about this is that this will give you both their baseline survival as well as their survival post-intervention if you add these things. So for example, if you take the 65-year-old class 3 patient with an EF of 20%, their mean life expectancy is 4 years. But if you now put them on an ACE, beta blocker, aldosterone blocker, and put in an ICD, their survival improves to 10 years. So this just gives you the magnitude of benefit that we get from current heart failure therapy. We honestly do not use either of these risk scores very often in heart failure clinic because we tend to rely on more objective data such as cardiopulmonary stress test results. So what about patients with preserved ejection fraction? As I mentioned before, some of these patients who initially have a preserved ejection fraction, for example, patients with hypertrophic cardiomyopathy or amyloid cardiomyopathy will progress to having left ventricular dysfunction or left ventricular systolic dysfunction. Those patients are very much candidates for ventricular assist device therapy. But patients, again, any of these patients, hypertrophic, restrictive, constrictive amyloid, even if they're not candidates for VAD therapy, are candidates for heart transplantation. And really, anybody with any heart failure, if people are concerned, need to be referred for more advanced therapy evaluation. So when we see people in clinic, what kind of things do we think about? So patients get referred. So we confirm the data that we get. So do they have low ejection fraction? Are they in optimal medical management, which both includes, are they on all the right medications that they should be on? And is their heart failure adequately diagnosed? So often, or at least once in a while, we'll get referred patients on who ischemic cardiomyopathy is actually missed. So patients were not adequately capped. Patients on who amyloid or sarcoid cardiomyopathy were missed, meaning patients for who potentially additional therapies can be considered. Once all of that was either ruled out or adequately addressed, we again will confirm objectively with things like VO2, frequent hospitalizations, how sick patients are. And then they will enter the workup queue. Essentially, heart transplantation is still the gold standard for advanced heart failure therapy. But potentially, if patients are not eligible for transplant, if they're too old, they're too overweight, they have a recent malignancy, or they have other contraindications, then they will be referred for ventricular assist device therapy. If they do not have any of these contraindications, then they will potentially either proceed to try to undergo heart transplantation, or they will get a ventricular assist device as a bridge to transplant while they're waiting for their heart transplantation. This is sort of a similar workup, again, trying to discuss the importance of using objective data such as VO2 in order to try to risk stratify patients. So what's involved in evaluation for advanced therapy? What will happen to your patients if you send them to us, for example? So a pretty thorough process, actually. So patients will make sure that their coronaries have been looked at. They'll get chest imaging, abdominal ultrasound, pulmonary function tests, all to try to risk stratify for whether or not they potentially have other contraindications or have other comorbidities which are going to be limiting their survival more so than heart failure. We will refer them to the appropriate specialist, so infectious disease, to make sure there's no active infectious issues. Nephrology, if they have renal dysfunction. Gastroenterology, in case they need a colonoscopy for primary screening, or there's other concerns. Everybody will get seen by a social worker for a variety of reasons. Patients need caregivers in order to undergo these therapies because significant family support is important both physically to get patients to appointments as well as to provide emotional support. Psychiatric evaluations, so depression, anxiety, substance abuse are all very common in this population, and all of this gets thoroughly evaluated. Financial evaluation is important, and then all of our patients will get palliative care evaluation, partly because we know that without therapy, this is very much a fatal disease. And so to give patients a better sense that they understand exactly what the risks and benefits of this therapy are to make sure that they truly are interested in what's about to happen. So referral for VAD is really just the first step. This is some recently presented data about 600 patients who were referred for VAD therapy to an advanced heart failure program. So out of 600 patients, the majority actually did not wind up receiving a VAD. And this was for a variety of reasons, both for physician reasons as well as patient reasons. About half of the patients actually didn't want one. So upon hearing what this entailed, they did not want advanced therapy, and they decided or could be managed medically further. About a third of the patients were referred when they were already too sick. So patients either in cardiogenic shock or with significant end organ dysfunction, being cirrhosis, significant renal disease, severe COPD, are no longer candidates. Or patients who do not have adequate social or financial support are potentially also excluded. So briefly, so what are some contraindications for advanced therapies? So if patients are likely to die for another reason, if they have severe COPD, so an FEV1 absolute of less than, let's say, 1, or severe obstructive or restrictive disease, those patients primarily probably have pulmonary limitations, more so than cardiac limitations, and so even replacing their heart will be of little value. Diabetics with severe end organ damage, people with severe peripheral arterial disease, patients with cirrhosis, and those with active mental illness or active substance use are really not candidates for advanced therapy. A few transplant-specific evaluation concerns. So pulmonary hypertension is a problem for heart transplant specifically because you don't want to put in a heart that has never experienced elevated pulmonary resistance into a patient who has elevated pulmonary pressures or elevated pulmonary vascular resistance. So we try to do our best to make sure that patients have reversible pulmonary hypertension before they undergo transplant. Age cutoffs are fairly strict for transplant. Generally, people need to be under age 70, although I think Dick Cheney was transplanted at 70 or above. So morbid obesity is a contraindication. So if people are morbidly obese, they probably will not get a heart transplant. Those with underlying infections will also not get a heart transplant because of the immunosuppression that's required and may exacerbate infection. Regarding some ventricular assist device specific concerns, so right ventricular dysfunction is a problem for patients with a left ventricular assist device because you still need adequate right ventricular function in order to supply adequate preload to the VAD. And those patients who have severe right ventricular dysfunction are potentially going to not do well with the LVAD alone. Those patients who are close to dialysis may be turned down for VAD therapy because it is practically difficult to dialyze VAD patients at this time in the community. As I mentioned before, a lot of them have no pulse and so have a very difficult to check blood pressure. And so dialysis centers are very hesitant to accept those patients. Patients who are immunocompromised or patients who are at high risk of bleeding may also not be candidates for this therapy. So this is pretty much the end, just a few final comments. So advanced heart failure is very common, and I think it's easily under-recognized. Patient selection is important, so we don't want to put these in patients who are too well, but we don't want to wait until they're too sick. And both VAD therapy and heart transplant provide significant improvements in morbidity and mortality for these patients. Thank you.
Thank you, Dmitry. That was a very nice talk and a very nice and appropriate overview. Start with some questions. Henry.
Yeah, certainly we find at least some do that. So I think, when people have severe tricuspid regurgitation, it's still potentially possible to evaluate the jugular venous pressure because you're looking at their pre-V wave pressure. So you want to try to see if you could, on physical exam, figure out a point before systole starts. Because obviously with tricuspid regurgitation, you're going to have a big systolic wave. But before that wave happens, there is potentially a point to where the pressure comes down where it is interpretable. But honestly, that is that adds another layer of complexity to the physical exam.
The last question is, this talk wasn't necessarily about diastolic heart failure, but right now is aldosterone the only thing prophylactone the only thing that maybe class 1 and the rest are we use but aren't proven? And is there anything coming up?
There's nothing really coming up. I think there's a lot of debate in the literature about what heart failure with preserved ejection fraction actually is. There was an editorial written about 5 years ago that said I think the title of which was there are multiple class 1 approved therapy for patients with heart failure with preserved ejection fraction. And what they commented on is that these patients require treatment of their blood pressure, of their lung disease, of their renal disease, of their anemia, of their diabetes, of their end organ dysfunction. And that really is the treatment for the majority of these patients. That really blood pressure management, volume management is the way to keep most of these patients reasonably healthy. But as far as I know, there's nothing specific for diastolic dysfunction specifically.
Other question?
Yes. They are long. So, the transplant listing criteria at this point will risk stratify patients into 3 groups. So there's patients that are listed as 1A, which is the highest severity, 1B, which is sort of lower severity, and then class 2, which are essentially patients who will never get a transplant. Waiting times vary by region across the United States. So patients in Texas, California, and other places will get transplanted much faster than in other places. The other things that will affect patients' wait times are things like their blood type. So patients who are O are out of luck. If you're AB, you will get an organ much faster, as well as your body size. So the smaller, the better. I would say on average, a normal-sized man who is blood group O at even the most highest status will probably wait weeks to months or more to get heart donor offers. Patients who are either very large, have antibodies, again, blood group O, may wait months to literally years, even at the highest status, to get offers. Which is why more and more patients are being bridged, because once you get ventricular assist device, you're now stable and you potentially are able to wait 2 years to get an offer, whereas you could not do that on medical therapy.
Yeah, I think for a large oat now it's approaching about 2 years, isn't it? But yes, another question.
Our new governor, Bevin, has told us that our Medicaid program is unstable for financial reasons. And I would agree with him, but no more or less than any other segment of our Medicaid system. What can you tell us in Kentucky, whether you're to get a heart transplant, it sounds like a restricted assist device also depends as much on a wallet size as anything else. What can you tell us about the cost of a PAD device?
Sure.
Compared to initially a maintenance, compared to transplant or regular medical therapy?
Yeah, so obviously these are much more expensive than medical therapy, especially considering the medical therapy is death within 6 months. So the pump itself costs about $100,000. I think that there's published data about the cost for both transplant and VADS within the first 6 to 12 months, and they're similar. I think they're probably in the $250,000 to $500,000 range for over the first 6 to 12 months. So this is expensive therapy, but at the same time, this is life-prolonging therapy. So, therapy that could extend the life of patients by 5, 10, 15, or 20 years. I think it's something to consider. Most insurances will approve this therapy. I think it's a little bit state-dependent as well. I think Kentucky is pretty good. The vast majority of patients are able to get coverage. The hospital will do a significant amount of charitable work for patients. There are clinical trials that are potentially available to help subsidize the cost. There are not many patients who get turned down solely for financial reasons.
I think there was one study in Circulation, actually, which compared advanced heart failure patients in the last 6 months of life and look at the cost. And that actually was reasonably equivalent to having a left ventricular assist device. Of course, the cheapest thing is death, but to die at home, but a lot of these readmissions are incredibly expensive. The problem with VADS is still there is still a high complication rate and cost afterwards. Once that complication rate comes down, then really it should be a far more cost-effective therapy. We're moving towards that, but at the moment it's not cheaper, but it hopefully will be.
At some point, VADS will be fully implantable, so transcutaneous charging is technology that exists and I think will evolve over time. Once these things get fully implantable, like a defibrillator, things will get better. The next generation of VADs are about the size of a AA battery and can be percutaneously implanted, so no longer requires sternotomy. And when you look at those kind of things, plus transcutaneous charging, so no longer needing a driveline or batteries, I think the morbidity will improve significantly.
So no more questions. I think it's 9 o'clock, so thank you very much. That was a great talk.
Thank you.
The drugs that are indicated for low sodium is a bad predictor.
Mm-hmm.
What's the clinical advantage? Do they just make numbers better?
Well, yes,
or do they really